Now, there is a rumor, a lot of people think that we as a microscope training center are very snobbish and we don't allow anyone other than endodontists into this territory, but it's not true. We don't really care what degree you have or what your qualifications are. The only thing we ask for is that you're a serious clinician. So, Deepesh finished his BDS from Maruti Dental College, Bangalore in 2006 and completed his MDS. Wait for it, it's not endodontics, MDS in oral medicine and radiology from BITS, Bangalore in 2011. And he started a private practice in 2014 in Hubli, and he's been there ever since. And we've all been following Deepesh, and it's an absolute treat to watch his progress over the years. And most of you in the group know he's one of the pillars of the WhatsApp group, posting case after case. So, well done, Deepesh. Like Liba said, there may be many who may not post your like and comment and things like that, but in our hearts, we very much appreciate the kind of work you do. So keep posting, keep inspiring us, and over to you.
Right. So good afternoon, one and all. I hope you all having a great time. So allow me a few moments journey as where I have graduated, post-graduated, everything is said by Sijo sir. So I would not go into it. So the first endo conference which I attended was in Roots, that was conducted at Chennai in 2014. There I came across some world-class clinicians. As a oral medicine, as a non-clinician, I didn't know these all things existed. So it was like a dream where I was seeing so many things. Finding MB2 was a lecture, calcified canals. I came across Venkat sir, Sergio Nicola sir. For the first time I've seen them. So I back then I didn't remember any name. Right now I know them. So met Siju sir also for the first time, so coincidentally, so small memory, right, at Roots Chennai in 2014. So that's how I met Siju sir for the first time. Yeah. So then in 2014 November, I attended 2-day workshop, and we all know when we see the tooth under microscope for the first time, how clear it looks. And that was one feeling which I had in back end of the mind. 2016, I got my microscope in February, and that's how I started my microscopic journey. We'll start with the cases directly. Yeah. So, and few of the workshops I did. One is under Dr. Ashwin, rubber damology, and one under Dr. Sergio Nicola, instrument retrieval and documentation. So it was great help and amazing course. Right. That's my private practice, my clinic. Is it clear, sir? Yeah. So that's my private practice there. So we have one chair, ceiling mount microscope, and that's a small waiting area. So that's how we start our work today. So my topic would be short presentation on clinical management of cases difficult to isolate and difficult to restore. Right, we'll start with the case. Okay, so this was a case, 18-year-old girl came with a symptomatic lower left second molar. Right, we all face this. There is a grossly dissected, as we can see in the pre-op, lower left second molar, and the third molar is in close proximal to the lower left second molar. So the challenges were access, placing the matrix band, and also isolation, right? So we did a gingivectomy by raising the flap, and post gingivectomy we got the access to the tooth, and at this step we also trimmed a bit of lower third molar to make space for the matrix band to be placed here, right? So we trimmed the tooth. As we all know, in the pre-op the tooth was very close to the second molar. So post that, what we did, we chose a molar brinker clamp and isolated this lower left second molar. And one more thing what we did was we passed the floss tie over the clamp and dragged the rubber dam sheet slowly beneath the gingival cavo surface of the second molar. I'll repeat again. I took a floss tie, pass it over the clamp. I'll show you a video. There is a video. Pass it over the clamp and then dragged it slowly behind. This tip was so good. I have isolated these type of cases, many I'll be showing you. And then placing the matrix band, Tor VM, stabilizing by the flowable composite, because there was very less space to stabilize the matrix band. So post that, a pre-endo buildup was done. So I'll just show the video of, this is another case where I just made a short video. Yeah, so we basically passed the floss tie over the clamp so that you can bring the rubber dam sheet. In that case, it was a distal cavity, so I was dragging the sheet beneath the tooth surface, gingival cavo surface, right? So we all know this, but putting over the clamp is a good practice, and we get a very good isolation, a very good dry field, right? So then that's a pre-endo build-up done, sutures to close the flap, and the next it was pretty simple, cleaning, shaping, obturation, restoration, that's a pre-op and that's a post-op. So we got this distal pre-endo build-up done with a floss tie as a great tool to help. The second case where we again use a floss tie. So this was a 22-year-old girl who was referred to us. She reported to us with a sensitivity, severe sensitivity. Previously, she had undergone a lower third molar extraction where you can see there was an iatrogenic damage done. So the distal part of the second molar was chipped here, the distal part of the lower right second molar. So we took the wingless clamp, isolated the tooth, and again back, same way, we dragged the rubber dam sheath. I'll just show you in the next pic. So if you see this, the rubber dam sheath is below the gingival cavo surface. So we get again a dry field. So this floss tie would help us a lot in these type of cases, the distal part of this. And then the rest of the procedure was simple, air abrasion, flowable composite, bulk flow. There was no place to place the matrix band, so it was a freehand composite done here. Yeah, that was a 1 year follow-up. So this is a 1 year follow-up of the clinical pic. Right. So no sensitivity. Coming back, next case. So 65-year-old man came with the upper left tooth with a deep decay. You can see in a pre-op radiograph, there was a deep decay. We all faced this situation and a lot of gingival bleeding and inflammation. So we took a small clamp here on the upper 8, wingless clamp, and so that the coronoid process would not interfere. And then, yeah, gingivectomy. And after removal the decay, there was a problem. What was the problem? Was there was a concave outline of the tooth. Now to place the matrix band was a challenge here again back. So we packed in Teflon here, which was acting as a fake gingiva here, and then placed the Tor VM matrix band and stabilized again by a liquid dam, and we did a pre-endo build-up. Pre-endo build-up was done a bit differently. What differently, I'll just tell you here. So we used the floor and the wall. We use the floor and the wall to do a pre-endo build-up. So we get an extra tooth surface or extra substrate, because as you know in the previous pic, there was a concave margin there, right? So in consequent visits when we do endo, there are chances that the pre-endo build-up may fail or it may come out, right? So to increase that bondable surface, so using this would be a nice idea to do a pre-endo build-up. And the rest of the procedure was simple, removing Teflon and then, yeah, shaping, restoration, that's pre-op and post-op, right? So using Teflon is packing into the gingiva and stabilizing the matrix band would be a great way to isolate. This is a similar case where I have again used the Teflon and matrix band stabilization, but a little variation. So I'll show you this. A 28 millimeter long symptomatic canine, grossly destructed. Again, we come across this situation. And gingivectomy, decay removal. Yeah, so same way Tor VM matrix band is placed, Teflon is packed, and it is stabilized by the liquid dam, and air abrasion was done. And yes, then the rest of the procedure was simple after the pre-endo build-up. Obturation, post and core, and canine extrusion, a slow canine extrusion for 3 months was done here to get the enough tooth structure. You can see it was almost below the bone, the restoration, subcrestal, sorry. Yeah, so this was the tooth we got. That was the final crown. That was immediate after placing. So the gingiva is bleeding a bit. And this is the pre-extrusion, that's the post-extrusion. So after the crown, right? Now this is the situation we come across on the daily, a grossly dissected teeth. This is not a very, simple case in the sense, there was tight contact between the mesial aspect and the distal aspect. So before jumping into the, putting the rubber dam and starting with the tooth, what I did was here is, I took a crown cutting burr and just open up the contact for the mesial and distal. In any ways, this tooth is going for a crown, right? So we opened up the contacts rather than struggling with the rubber dam sheath in a tight contact. If you see here, there is a very tight contact between the premolar and the molar, right? So opening the contact, sometime modifying the tooth before putting the rubber dam would be a great idea. Isolating plus also placing the matrix band would become much easier. Okay? So opening the contact or modifying the tooth would be a great idea. The rest of the case is simple. Yeah. Class 5 are always little difficult, two reasons. One is gum interference and the gum bleeding, and also the clamps are not stable in class 5. So what I faced, what I do is now 2 clamps or a double clamp technique, a primary clamp on a second premolar, and the B5 clamp, which is your 212 clamp what we use, we cut it into half pieces. So it is called as a B5 clamp, engaged deeply onto the premolar. The canine is stabilized by floss tie. Primary clamp, a premolar, normal wingless premolar clamp, a B5 clamp, and a floss tie would serve. That was the pre-op, a re-restore case, and this was this. I'll just show you a little, yeah. One more, just I wanted to add a point apart from isolation. Sometimes we have to protect the isolation. In class 5, when you are drilling the edges on the edges of the cavity, it sometimes the burr slips and go into the rubber dam sheet. So to avoid that, we can use this handy, a spoon excavator. I'll just show you the video. So we can use a spoon excavator as a guard, and you can keep on changing wherever you are drilling so that it doesn't slip there and go slowly. So you can remove the part which you have to remove the decayed part and becomes easier. Okay, so small clipping for that, right. Okay, so this is the isolation, post air abrasion, post selective enamel etch. Teflon was packed here into the gums and we got a clean surface to restore it now. Yeah. So class 5 isolations, double clamp technique. So another tooth where again a double clamp technique, again a grossly dissected premolar, second premolar. So he came with the acetopical abscess, pus was drained in the first visit. Primary clamp, so I'll talk more on the isolation. The primary clamp on the molar, wingless clamp, and a B5 on the second premolar, and it was stabilized by the flowable composite, as you can see here. Teflon was packed into the gingiva. The rest of the procedure is simple. You get a clean dry field, and yes. So 2 clamp. This is the case where there was a fractured upper central incisors and lateral incisors with a supernumerary at the palatal, and patient was symptomatic. Now, rubber dam isolation, because as there was no space to place the clamp, we could have extracted the supernumerary at the first place. That also could be an idea. So to immediately start with that, what we did was, so 2-3 things. One is mark the tooth on the rubber dam sheet, which we all do. You are using smaller punch holes, smaller holes in the rubber dam sheet. Second, and third, the floss tie. So these 3 would help us to give us a clean picture and finish off our treatment with a great clean environment. And that's the whole pic, because this mirror, small mirrors wouldn't give that. So this unclear picture, but still we can show a small B4 clamp and a premolar clamp with all the tooth in the place. So with marking the sheet, smaller holes and the floss tie would help us to do that. Similar situation, there was a labially placed canine and you want to restore a proximal cavity. So similar situation, same way, punching smaller holes and marking, and yes, you can get the isolation. In simple isolation. Yes. Last case. This idea I borrowed actually from Venkat sir. I have seen in one of his cases. So where the 62-year-old lady came with a dislodged crown. So I have seen Venkat sir using these 2 clamps. So I tried to CTRL-C, CTRL-V, copied it. So I used a B4 clamp, a B5 clamp on the lower second molar. It will not be stable initially. This will be rocking when you put it, but you can stabilize it little by flowable composite and you get decent enough time to finish it. But definitely little wobbly, but still decent enough to get those type of isolation where none of the clamps usually fit here, or a crown lengthening or something would have been done if you want to really go about it. Right? Thank you. This was a short presentation, and without Siju sir, I wouldn't be standing here. Thank you so much. Thank you.
Thank you, Momento, for the presentation.